So I've shown you evidence that ENOX2 is present within the serum of late-stage cancer patients, within very early-stage cancer patients, and for patients who are undergoing recurrence. But what about young, healthy individuals? What is the frequency at which ENOX2 is detected within the serum of young, healthy individuals with no strong family history of cancer and no evidence of cancer? To answer that question, we have analyzed the serum of 25 males and 25 females between the ages of 29 and 39 for 100 serum samples total. The frequency of ENOX2 detection within this population was approximately 3%. This may represent the detection of very early neoplasms within this population that are yet undiagnosed. However, the 3% for this particular population is still about 1.5 to 2% above what you would anticipate if every single one of these individuals was going to be diagnosed with a clinically relevant cancer within the next 2 or 3 years. So based on all the evidence that I've shown you so far, these are the clinical utilities of the test. These are the claimed clinical utilities of the test. First, for confirmation of cancer presence and the tissue of origin in individuals. Second, to aid identification of cancers of unknown primary, which account for approximately 2 to 5% of individuals that present with late-stage cancers. These are individuals for which it is clear that they have cancer, but they have multiple metastases, and a pathologist is having a very difficult time identifying what the true primary tissue of origin is. And the third, for detection of cancer recurrence. Now, we are also investigating additional utilities for the Oncoblot test, including screening. We have very strong anecdotal evidence that the Oncoblot test is going to be useful for screening. We are also undergoing a significant number of both prospective and retrospective clinical trials to demonstrate this use. In the last part of the talk, which will be the longitudinal studies of ENOX2 detection within patient populations who eventually were diagnosed with cancer. So this graph represents multiple serum samples from the same individual, and these data are being prepared as a case report. Now, this individual, when he was diagnosed with prostate cancer, was 64. Fortunately, there were longitudinal retrospective serum samples available for this individual going back 16 years prior to a diagnosis of cancer. This individual is based on his medical records. His starting PSA was 0.8. After analysis of all of the available serum samples for this individual, ENOX2 was first detected in year 8. That's 8 years prior to a diagnosis of prostate cancer, when his PSA was approximately 4 nanograms per milliliter. No symptoms were recorded for this individual until year 16, which is 8 years after the initial detection of ENOX2 within these serum samples, and prostate cancer was confirmed in year 16. Now, after this individual was diagnosed, he went through several rounds of treatment, and so what this graph represents is a correlation between the PSA within all of these serum samples and an estimation of the amount of ENOX2 that's present within each of these serum samples based upon the diameter of the spot that was detected on the blot. Now, when increasing amounts of protein are detected by two-dimensional gel electrophoresis, it's not necessarily true that the intensity of that spot may change. However, the diameter of that spot will increase with increasing amounts of protein. Now, this is a useful way to estimate the amount of ENOX2 within a serum sample based on two-dimensional gel electrophoresis. When there are a significant number of serum samples are available for the same individual, and these serum samples can be run in, say, duplicate or triplicate to get a good estimate of the amount of ENOX2 present within these serum samples. So what I'm saying is that if you read some of our manuscripts, we occasionally use this kind of method to estimate the amount of ENOX2 present within each serum sample. However, for a single oncoblot, individually on a case-by-case basis, this is not necessarily a useful indication of the amount of ENOX2 present. Okay, and for the last amount of longitudinal data that I'm going to show you today, this was a very interesting retrospective study that we did involving individuals that were exposed to asbestos and were subsequently enrolled in a cancer surveillance program. This is a very interesting story. In the town of Whitnoon, Australia, this was the site of a very large asbestos mining and milling operation prior to the discovery that asbestos exposure is linked to malignant mesothelioma. After that link was discovered, the records of this asbestos mining and milling corporation were used to identify a patient population that were at a high risk for developing malignant mesothelioma. And from those employment records, they can also estimate the total asbestos exposure of this population. So some of these individuals elected to enroll in a cancer surveillance program for which there are medical records every year after they were enrolled, and for which there are serum samples, their serum samples were drawn and banked every year. Some of these individuals developed malignant mesothelioma, and they are available in a serum bank. And so we use these serum samples to investigate when, during cancer development, ENOX2 could first be detected within this particular patient population. So the sera of 7 individuals were investigated longitudinally for 8 to 13 years. That's how long those banked serum samples were available. And here I'm showing you representative oncoblots from a single individual. So the first serum sample was at negative 106 months. This is 106 months prior to a diagnosis of malignant mesothelioma. So this is approximately 9 years prior to diagnosis. This is reference protein 4.1. This is that alpha-fetching protein that I had shown you previously. And other than that, the blot is relatively clear. Now, initially at negative 50 months, so this is approximately 4 years prior to a diagnosis of malignant mesothelioma, 2 proteins can be detected, and those proteins become a little bit stronger over time. These 2 proteins are 2 ENOX2 isoforms that are simultaneously produced by malignant mesothelioma. And they are present within these serum samples all the way until the patient was eventually diagnosed with malignant mesothelioma at month 0. So this figure represents the longitudinal analysis that was done for all 7 of these individuals that were eventually diagnosed with malignant mesothelioma. On the x-axis, this is the months prior to a diagnosis of malignant mesothelioma, and each one of these, and here on the y-axis, this is the patient ID for all 7 of these patients. Now the black diamonds represent an oncoblot that was done in which 2 ENOX2 proteins were detected, both of which were specific for malignant mesothelioma. The white diamonds represent an oncoblot that was done in a serum sample in which no ENOX2 proteins were detected, and these gray diamonds that occur relatively early within disease progression represent an oncoblot that was done in which 1 of 2 of those ENOX2 proteins were detected by oncoblot. So from this analysis, for these 7 patients, ENOX2 was detected 4 to 10 years prior to a diagnosis of malignant mesothelioma for these 7 patients. Okay. So finally, I'm going to go over some of the most common clinical questions that we get from clinicians prior to using the oncoblot test. Okay. So the very first question is, if the ENOX2 marker is absent from a patient's serum, does this indicate or does this guarantee that an individual will be cancer-free for months or years afterwards? Now, I've shown you some very interesting data that ENOX2 can be produced very early during disease progression. However, this is not necessarily a guarantee that this will happen for every single individual. Cancers can progress at different rates. It is possible to be completely asymptomatic and to have no ENOX2 proteins detected within your serum, and then within less than a year, be diagnosed with a clinically relevant cancer. Okay. The second question that we often get is, are the number of ENOX2 proteins indicative of how severe the disease is or disease progression? And the answer is no. Because these different ENOX2 isoforms that are detected on an oncoblot, these are the result of differential splicing of that messenger RNA, which is tissue specific. So the number of ENOX2 proteins that are detected only serve to indicate a tissue of origin. They do not indicate that the disease is getting better or worse, nor can they predict disease progression. The third question we often get is the quantification of the amount or the estimation of the amount of ENOX2 on a blot indicative of cancer staging? And the answer is no, it is not. This is primarily because the amount of ENOX2 that can be estimated from a single blot is just that, it's an estimation. And there can be significant amounts of variation from patient to patient, and particularly from tissue of origin to tissue of origin. So in general, we say that the test is purely qualitative. We can tell you whether or not the protein is present or not. We can tell you the molecular weight and isoelectric point of each ENOX2 protein detected, which will suggest a tissue of origin. But the test is not quantitative. The estimated amount of ENOX2 proteins detected is not necessarily a useful number to provide on a case-by-case basis. And then finally, the final question is, how many cancers have been shown to produce ENOX2? Currently, we have 26 different cancers that we have investigated a significant number of serum samples for, and so we claim that we can detect at least 26 cancers from 20 different tissues of origin. So some of these cancers are from similar tissues of origin, or they produce similar ENOX2 isoforms, and so only 20 different tissues of origin can be differentiated. So this is my final slide. In conclusion, I've shown you that tissue-specific isoforms of ENOX2 are present within the serum of cancer patients. And I'll leave you with ENOX2 is produced by cancer cells. It is a cell surface protein that is shed into the blood sera and can be detected by the oncoblot test. And in comparison to other serum cancer markers, ENOX2 does have some obvious advantages. For instance, ENOX2 is cancer specific. A single test can detect 26 different cancer types, and we can identify the tissue of origin of 20, we can differentiate among 20 of those different cancer types. And finally, that ENOX2 is elevated very early during disease progression.